Have you been wondering just how to treat hearing loss, such as whether to go with over-the-counter versus prescription hearing aids? In this episode, I've interviewed an audiologist who will tell you exactly what you need to know to get age-related hearing loss effectively and affordably treated. We'll even tell you what to do if your hearing aids haven't worked out so far. Well, hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. Today's episode is part of a series that I'm doing on age-related hearing loss, and I am delighted to have audiologist Dr. Cliff Olson here to talk about today's options for treating age-related hearing loss. Dr. Cliff is the founder of Applied Hearing Solutions Clinic and also has a well-established YouTube channel, Dr. Cliff AUD, where he covers all kinds of things related to hearing loss and audiology. So welcome, Dr. Cliff.
Thank you for having me, Dr. Kernisan.
So, Dr. Cliff, you are an audiologist, and I thought it might be great for us to start off with you explaining a little bit like what is an audiologist and how do you usually help older adults?
Absolutely. So an audiologist is not a medical doctor, but we have a clinical doctorate. So we go through 4 years of undergraduate education, most often in communication disorders, and then we work into our 4-year clinical doctorate for audiology. Audiologists can specialize in a variety of different things, but hearing loss is usually at the top of that, but we also deal with vestibular disorders as well.
Okay. And so can you give a few examples of how you're usually working with older adults? What are the common reasons that you see older adults in your clinic?
Yeah, the most common reason is the perception of hearing difficulty. And whether they know they have a hearing loss or not, it usually shows up in other forms of communication barriers where they feel like people are mumbling, or they're watching the TV and they feel like the actors who are on TV just aren't speaking as clearly as what they used to. And so it often leads to the point where they want to get their hearing evaluated to find out what's really the cause of this.
Okay. So are people usually coming to find you directly, or are they usually being referred by their doctors?
Well, I think I'm a little bit of an anomaly, but most patients end up finding us through online content. But, one of the leading reasons why people will go see an audiologist is because they were recommended by their primary care physician to go get an evaluation.
So I know as an audiologist, you help people with all forms of hearing loss. But today I want to focus really on age-related hearing loss, which we also call presbycusis. And so there is, it is considered in primary care important to screen older adults for hearing loss because it's so common, so important, and then try to assist them. But often there's an issue with insurance coverage. Can you speak a little bit to, are your services, audiology for age-related hearing loss, usually covered by insurance?
Yeah, so the initial testing usually is. So individuals who have traditional Medicare, they can get a hearing test covered one time per year. And then, going in to see an audiologist, you don't need to have a physician's order anymore. Previously or historically, you had to have a physician order in order to have Medicare pay for that hearing test. Otherwise, you would have to pay out of pocket for it. But that has changed in the recent years. Now you can essentially go directly to an audiologist if you want to, or you can come in off of a referral from your physician. In either way, Medicare will pay for that. Now, you're probably, of course, aware that Medicare Advantage has kind of changed things. With Medicare Advantage, there typically is an out-of-pocket expense for a hearing evaluation if the provider that you're going to is not in network with essentially the third-party network that these Medicare Advantage plans work with. They can get pretty convoluted, which is actually one of the biggest issues that individuals who are older, who are of Medicare age, run into, is that they're not really sure what their insurance covers. If they have traditional Medicare, if they have any one of the numerous Medicare Advantage plans, it can literally be different for everybody.
Okay. Well, that's really great. I wasn't aware of that because I feel like last time I looked this up, it said that audiology services were only covered if it was a diagnostic exam prescribed by or requested by a physician. But it sounds like that has changed. And now if people have, especially if they have traditional Medicare, they can just go see an audiologist. And if that audiologist takes Medicare,
That's true. Yeah. So,
They can
and
get an
there's
evaluation.
typically we would have had to have had a physician order, and then even to recommend treatments and treat a patient, we would have to send off a document basically saying that this patient is cleared to receive hearing aids from their physician before we could even treat the individual. And that is a requirement that is no longer being enforced technically by the government. So you could actually go in, get tested, have that covered by Medicare, and then receive treatment without a physician order anymore, even though the hearing aid side of things for individuals who are of Medicare age on traditional Medicare does not cover hearing aid treatment specifically.
Okay. All right. And then I know you started your channel in part because you felt there was a gap between audiology best practices and the actual care people were receiving. This is something that you and I have in common. We're aware of best practices, the kind of care older adults should get, and the gap between that and what they actually get. And so can you just speak a bit to how should ideally an older person, what is the best practice for how their hearing loss gets evaluated and what usually happens?
Yeah, so there's best practices when it comes to the evaluation, and then there's also best practices when it comes to the treatment and follow-up care with that treatment. So initially, if we just stick with the initial evaluation, when you go in and you have your hearing test, that should be performed in a sound-treated booth. There are some places that will test your hearing, and you're in kind of like this little pod that's not completely enclosed, so you don't know if the results you're getting from that test are legitimate or not. The speech testing that you repeat back words to the person who's presenting you with words at an audible level, if that's not presented in a recorded fashion, so a recorded speech rather than live speech, if I were to actually say the words for you to repeat them back to me, you have to have recorded speech testing. Otherwise, you cannot generalize those results and compare them with other places that test you. Because if you have a tester, there's variability that's introduced with that. So you have to make sure the person testing you is not using their own voice to do the testing. You have to use recorded speech content for that. On top of that, you should also have speech and noise testing done, especially if you're reporting difficulty in background noise, which if you have age-related hearing loss, if you have presbycusis, you are going to have difficulty usually in background noise. So having a speech and noise test performed, which actually puts you into kind of like that noisy restaurant situation with all that noise that's around you, and then you have to listen for sentences and repeat those sentences back to the person who's testing you, and we gauge your level of performance there as well. And then you should have all of that information communicated to you in terms of how your test results came out. It should not be okay, I see what your results are, here's my treatment recommendation. Everything should be reviewed with you to where you actually understand what your hearing loss is and what's causing your hearing loss.
Okay. So what usually happens if people aren't careful? Is it just that they get put in a not very soundproofed booth and somebody talks to them a few times and maybe puts headphones on and has them listen to different sound levels?
Yeah. You should be listening for the beeps and either raising your hand or clicking the button, but you have to make sure that the results you get on the hearing tests are actually accurate. And if you're not following a best practice protocol for the testing, you don't know if the hearing loss that's coming out, that's being recorded and presented to you, is actually your hearing loss, which can lead to ultimately an improper treatment recommendation and then suboptimal performance with whatever that treatment was. And I'll give you a for instance here. So I have patients who come in, they bring in these audiograms that they had done at a different clinic, and I don't know how they were tested at that other clinic, but I can review that audiogram and then compare it with results that we have, and sometimes we see massive discrepancies between those tests. And then as we do some additional investigation, we identify, the speech testing that you had done with monitored live voice. So it inflated your performance on that particular test, where it might look like you're doing really good if you have amplified sound from a hearing aid, but then when you have recorded speech done, it identifies you actually do not do good with hearing aids because your performance is very, very low, and you might need to consider something like a cochlear implant instead of a hearing aid. So if you don't have that foundational hearing test done in a best practice fashion, you don't know if the treatment recommendation you're going to be getting is going to be a good one.
Okay. And so you just referred to the audiogram. I guess this is kind of like the written report summarizing the key findings. Can you take us through the key kind of parts of what is shown on the audiogram?
Sure. Yep. Yeah, so
Start over.
audiogram, they're very universal. So a lot of them will look very similar. And the first thing that everyone thinks of is like, okay, how do the beeps when I'm clicking the button for the beeps when I'm in the sound booth, how do those get annotated on an audiogram? And that's the X's and the O's on the audiogram. And usually the X's and O's are colored. So you have blue X's to represent the left ear, red circles to represent the right ear. And the further down you see the markings on this graph, the worse your hearing is in those frequency ranges. And it's like a piano keyboard. You have the lower pitches on the left-hand side, working your way up to the higher pitches on the right-hand side. Now, with presbycusis, the age-related hearing loss, typically what we will see is we'll see that someone usually has normal hearing in their low frequency ranges, and it starts to slope off towards the right-hand side of the graph into the high frequencies where they're having difficulty hearing those high frequency sounds. That is prototypical high frequency hearing loss for individuals who have age-related hearing loss. We're all probably familiar to some degree maybe with, you can go online and actually watch videos where they have a progressively increasing high frequency sound, and all the young kids who watch and listen to that video, they can hear the really high frequency tones, but the adults, they typically stop hearing around 3 to 4,000 hertz, and that is the sign of early onset age-related hearing loss or age-related hearing loss in and of itself.
Okay.
So that's the first part. So the X's and O's on the graph, that is your air conduction thresholds. You also have bone conduction thresholds on that same graph, and these look like angle or square brackets. What we're testing you on there is if we bypass the entire outer and middle ear. So think of your outer ear as your ear canal, your middle ear is the eardrum, and that middle ear cavity that has the ossicles that then sends that vibration of sound into your cochlea, which is your hearing organ. All of the damage for age-related hearing loss is inside of the cochlea. So what we can do is we can separately test with bone conduction, sending the vibration of sound through your skull directly into your inner ear. And if we see a separation in the brackets and the X's and O's, we know that something is impeding the flow of sound through the ear, like earwax or something like that, or a perforation of the eardrum. So we need to make sure that the X's and O's on the audiogram also have the associated brackets for the bone conduction lining up very closely to them. If those are lining up very closely, again, this is a sign of presbycusis or age-related hearing loss.
Okay. So you mentioned actually, that there's like a video where it gets higher and higher, and I guess you can watch and see. Can you just speak quickly to obviously what people need to do is come see an audiologist and get an evaluation done according to best practices as you've described. But in the meantime, if they're watching this and wondering, like, do I actually have hearing loss? Can you speak to any of the other kind of quick available do-it-yourself tests that people can look for? I imagine there are apps at this point. Actually, I know Hopkins has one, like Know Your Hearing Number, which I think seems to see like what's the softest decibel you can hear. But yeah, can you speak to a few of the quick ones?
Yeah, there's a couple of them out there. There's a test. I don't remember the name of it right off the top of my head, but you can actually call in. I think it's called like the National Hearing Test. And you can Google this. You can call a phone number and it will actually do some form of a speech and noise test. So it can calibrate based off of that to tell you whether or not it believes you have a hearing loss. So that's a very simple one to do. You don't even need a smartphone you could have a rotary phone and do that particular test. You do have a variety of different smartphone apps that you can use to test your hearing loss. There are websites that you can go to. Usually the hearing aid manufacturers like Phonak and Resound are two that I know of, that if you go to their websites that they have a hearing screener that you can do, and it will give you a likelihood of whether or not you have hearing loss or not. One of the best ones that I know of is hearingloss.com. If you go to hearingloss.com and you do their hearing screener, not only will it take you through and indicate if it feels like you have a hearing loss, but it can get you referred to someone for further testing. If it does identify that you have a hearing loss, it's called the Guided Hearing Experience, which is fantastic. And then if you're one of the millions of people, I think it's millions, who own Apple AirPods, you can even take a hearing test with an iPhone or an iPad wearing Apple AirPods. And so that's another great easy way to get an initial evaluation done. None of them are as accurate as going in, of course, as you mentioned, to see a hearing care professional to have a best practice test done, but at least gives you a starting point in understanding if you might have a hearing loss.
Right. If it's, if it's true when your family keeps saying, you keep not hearing me, this is one way that you might be able to start resolving the issue. Okay. So let's say now that somebody comes to see you, gets the evaluation, and mild to moderate hearing loss is confirmed. I would love for you to take us through what are an overview. I know there are lots of options. Can we go through an overview of what are the current options for treating hearing loss, and maybe you can compare them for us?
Yeah, absolutely. So I typically break these down into 3 different categories. You have the general amplifiers. So we're talking you put something in your ear or you wear a pair of headphones that has amplification capabilities and it just increases the volume of everything. That's one way that you can kind of approach treating that hearing loss, because the hearing loss isn't that bad when you're in that mild to moderate range. You can sometimes get away with a low cost option to just increase the volume of things for a period of time that you want to use it for. Then you go to the second category, which is over-the-counter hearing aids. So these are actual hearing aids to some degree. They're over-the-counter. They're not usually as advanced as some of the prescriptive level hearing aids, but they can be customized a little bit. So if you have more of a high-frequency loss, you can typically boost up those high frequencies a little bit more than what you do the low frequencies, and those will typically give you a little bit better treatment outcome than if you just use something that increases the volume of everything. And then you go to the prescriptive route. So these are the hearing aids that have the full capability of adjusting them and a ton of different digital features that you can utilize to optimize hearing treatment outcomes. Now, if you have a mild to moderate hearing loss, you can literally fall into any one of those 3 categories. It just depends on the type of performance that you're looking for. There are risks associated with going with, the generalized amplifiers. There is the potential that you'd be under treating your hearing loss going with either those or with over-the-counter hearing aids. But to be fair, there's also the case that you might not be optimally treating your hearing loss with the prescriptive level hearing aids either if they're not fit and programmed the right way. So I would say that if nothing else, you have to dip your toes in the water with something. If you have a hearing loss and you're like, I don't know if I want to go the prescriptive route yet, I feel more comfortable going the over-the-counter or general amplifier route, I say go ahead and do it. Get an understanding of what it's capable of and what it's not capable of, and then work your way up that food chain.
Mm-hmm. And you mentioned AirPods earlier. So apparently AirPods are also now being used sort of as, I guess, do they count as over-the-counter hearing aids? Where do you put AirPods in this?
I would put AirPods firmly in the over-the-counter hearing aid category. They kind of market it as clinical grade hearing aids, which I think is very misleading. Uh-huh. But I think that their capabilities, what do a pair of Apple AirPods Pro 3 cost nowadays? I want to say $249. And those $249 Apple AirPods will outperform other over-the-counter hearing aids that cost a couple $1,000s. So, if you're looking for the absolute lowest cost way to get some level of over-the-counter hearing aid treatment, Apple's a good route to go. Yes, there are limitations, particularly going into background noise and trying to hear there. But if your main area of difficulty is hearing and understanding the television, which you can also stream audio into the AirPods Pro, or if you're just trying to hear conversations at home and quiet, you can typically get away with using the Apple AirPods and do a pretty decent job.
Mm-hmm. Okay. And then what if it's moderate to severe hearing loss? How does that change the treatment options?
Yeah, that really kind of limits your options really when it comes to the first 2 categories of the amplifiers and the over-the-counter hearing aids. They just do not have the gain capabilities. And when I say gain, I mean amplification capabilities of the prescriptive level devices. Prescription level hearing aids, you can change out receiver strengths. And when I say receiver, I mean speaker strengths of those. Someone who has more of a moderate level hearing loss, you don't need a super power or ultra power hearing aid receiver. You need a standard power receiver to amplify it to the levels that you need. But then as you kind of progress up, and you have to remember that not everybody has a flat hearing loss. You don't have moderate hearing loss at every frequency. You might have moderate hearing loss at the low frequencies, moderately severe in the mid frequencies, and then profound hearing loss in the high frequencies. So you have to have a device that can be custom tuned to not over amplify certain ranges that you do not need a ton of amplification in, but that also have the capability of amplifying the high frequencies a lot more. And there's a variety of prescription level hearing aids out there. And remember, when I say this, please, is that these hearing aids can be set up in a variety of different ways. They can either be optimized perfectly for an age-related hearing loss, or they can be optimized very poorly, and you get very similar treatment outcomes as what you would get from an over-the-counter hearing aid.
Okay. So it sounds like if the hearing loss has reached moderate to severe, I mean, if you really want like decent help, you're going to have to look at prescription ones, which is a more sophisticated device with more capabilities. And you should work with an audiologist to help you take advantage of those capabilities so that you get your hearing properly treated. And when people get the audiogram and the report, does it put them in that category, mild to moderate, moderate to severe, or, what are they being told?
Yeah, so when you get the review of the audiogram done with the audiologist or the hearing instrument specialist, they will typically put an overlay of the severity up there so you can see where you're at on that. And if you have any of those X's and O's fall below that mild to moderate line, then okay, I'm kind of out of the range of what an over-the-counter hearing device can do, and I know I need to pursue more prescriptive level amplification.
Okay. And then I would love for us to talk a little bit more about prescription hearing aids. I mean, first of all, I imagine you hear this all the time. I certainly do, that people have gotten prescription hearing aids and they didn't work, right? And so can we talk a little bit about why that's such a common complaint? What should the process be so that people get something that works for them?
Yeah, great question. So we have market track data that's out there that's been staying pretty stagnant we're at about 83%, how would we say this? We're at about 83% satisfaction with prescription hearing aids at this point. Now, to be fair, like in the 1980s, it was at like 60% satisfaction. So we have increased a lot of satisfaction with prescription level hearing aids. But since 1989, we've been stuck at that 83% satisfaction with prescription hearing aids, and the hearing aids have become markedly better. Like the hearing aid technology that we're working with now is light years ahead of what was available in 1989. So it really makes no sense that our satisfaction levels would not have increased, right? And it really comes down to the fitting and programming of those hearing devices. If you take the most amazing, and I have a great overlay for this, and I'll share this overlay with you, but there was a study that was done in 2012 by doctors Levitt and Flexer. And what they identified is that if you have the most advanced hearing aid technology that was available at that time, and you had those hearing aids fit on what we call first fit settings. So you basically take the information from the audiogram, you enter it into the programming software, and you just auto program the hearing aid, which is how 70% of hearing aids are fit and programmed today. That those hearing aids significantly underperformed in background noise compared to the same hearing aids fit and programmed following a best practice protocol, including real ear measurement. And the crazy thing about this is that even an old analog hearing aid from back in the day, and we're comparing old analog with these new fancy digital hearing aids, even the old analog hearing aid outperformed the new digital hearing aids when real ear measurement was performed on the old analog hearing aid, but was not performed on the digital.
Wait,
so that tells you right then. Sorry, go ahead.
I'm sorry to interrupt you. So you've said real ear measurements, I think, a few times. What is that?
Yeah, real ear measurement is a way that a hearing care professional can verify that we are meeting your hearing loss prescription. So essentially that we're providing enough amplification to restore access to missing speech information. So we essentially take and create a prescription based off of your audiogram, your X's and O's, but then we put a probe microphone tube inside of your ears along with the hearing aids because everybody's ear canal size and shape is different. So that will change the perceptual amplification that you receive from a hearing aid. So you could theoretically have two different human beings with the exact same X's and O's on the audiogram, but both of them need completely different amounts of amplification to overcome the exact same hearing loss. So if you do not do that real ear measurement procedure, that verification procedure, your hearing aids that you probably spent thousands of dollars on will perform worse than an old analog hearing aid that you could spend $50 on eBay.
Right. Okay. Well, that's very interesting. I'd never heard of the real ear measurement. So that's an important component that is not part of the initial audiology evaluation because it's assessed as you're doing like the fitting and kind of fine tuning, right?
That's true. Yeah, that goes into more of the treatment process rather than the evaluation process, but it's
Mm-hmm.
kind of a way for us to evaluate our treatment. And
Mm-hmm.
like I said, about 30% of hearing care professionals do real ear measurement regularly. So it's actually harder to find someone who does that than doesn't do it, unfortunately.
Okay, so it sounds like that's something people can know to ask about, actually, if they're going to work
100%.
with an audiologist is, do they do real ear measurements as they help fit, your hearing aids once you have them.
That is correct. And any answer other than yes, we do it on every patient is unacceptable.
Okay. You heard that, folks. Yes, they should be doing it on every patient and especially planning on doing it for you.
Exactly.
Okay. So we were talking about why do people complain about their hearing aids so much? And it sounds like one issue is that often they're not getting this real ear measurements, which is so important that it can even get better performance out of an old analog hearing aid than out of the new digital ones. And so I imagine if you combine that real ear measurement with the new digital ones, it should actually be possible to get people pretty good results, right?
Oh yeah. The treatment outcomes we can obtain today are insanely good with hearing aids. And I know that there's probably people even watching this right now that are like, well, I got hearing aids and I don't see how these could restore my hearing to any capacity. I'd rather leave them in my drawer. We call those
Mm-hmm.
ITD hearing aids, in the drawer hearing aids, instead of in the ear ITE hearing aids. But the amount of benefit that we can get now with the digital technology that's available, the artificial intelligence, like the Bluetooth capabilities that we have, if you combine that with a best practice protocol that includes real ear measurement, you can get substantially better treatment outcomes. And the other side of this, to prevent dissatisfaction with hearing aids, is that the physical fit is so important of a hearing aid. And the style goes into this a lot. So there's some individuals, especially individuals with presbycusis, age-related hearing loss, receiver and canal hearing aids, where you have the device behind your ear with a small little wire that's pretty much invisible that
Uh-huh.
goes down into your ear canal with the receiver or speaker in the ear canal, is typically the most optimal option for individuals with this type of hearing loss. So if you end up getting a hearing aid that fills up your entire ear canal and blocks your natural low frequency hearing that's still pretty good with this type of hearing loss, you end up getting a bad treatment outcome with that. So you have to make sure that the physical fit is done correctly as well as the programming of the hearing aid.
Mm-hmm. And what are the main types of prescription hearing aid that are available?
Yeah, so the number one most common that's recommended is the receiver and canal, the one that I just mentioned. You
Mm-hmm.
also have what we call behind the ear or BTE hearing aids. Now, these ones, they still go behind the ear, of course, but they have a thicker tube that goes down in front of the ear with a big custom ear mold to trap in a lot of amplification inside of the ear. So if your age-related hearing loss has been growing for decades, and you're at the point where you're at a severe to profound level across the board, you're likely going to need a BTE hearing aid to create enough amplification to overcome the hearing loss. But you also have completely in the canal hearing aids. These are great for individuals who have more of that mild to moderately severe level of hearing loss where it completely goes inside the ear canal. If you tell someone to look inside your ear, they may be able to see it. And then you have invisible in the canal hearing aids where these things go so deeply inside your ear, comfortably I might add, but you tell someone to look in your ear, they're like, I still don't see anything. So there's a whole wide range of different hearing devices that can be used traditionally to treat presbycusis.
Mm-hmm. Well, I know people, especially if they're closer to middle age, are often a little reluctant to have hearing aids because they don't want to feel old, quote, right? So are the invisible ones more popular? But I imagine they're not as powerful for
So it's
amplifications.
crazy that you bring this up because the stigma to a large degree is going away. This is something that we're not seeing a whole lot of nowadays. And I think the reason is, and I don't know exactly, but I think the reason is that the younger generations are also more, I would say, techie. And I would also say that they're like, listen, I'm looking for optimizing my life rather than worrying about someone else caring if I have a hearing aid on or not. And so what we typically see now is that the younger individuals that back in the day, they're like, oh, they don't want anyone to know. So get the invisible lyric device that goes completely inside their ear canal so no one will ever see it. Now they're like, well, I want the one with the most features. Like I want to be able to stream audio from my phone into my ears. I want to take phone calls hands-free. I want to stream my TV into my ears. I want it to be rechargeable where I don't have to fiddle with these battery packages. So they're looking for more optimization nowadays than what they are looking for invisibility, which is definitely a generational change that we've seen.
Mm-hmm. Okay. Great. So yeah, and now take us through the process of generally getting like the right prescription hearing aid. How do you help people through this process, and what should people expect? I will tell you that, I have members of my extended family who were told they should get hearing aids and got sort of like overwhelmed by the options.
So yeah, I can understand that because I think a lot of clinics, what they do is they're like, okay, you have a hearing loss. Now here's all the 18 different options that you can do. Like, which you tell me, what are you interested in? I don't subscribe to that model. So what I believe should happen when you go in for this initial evaluation, even before you go into the sound booth and get your hearing tested, we should be identifying all the different areas that you're having communication difficulty and what the priorities are that you have from a communication standpoint and a hearing standpoint. Once we know that, then the audiologist can go through with the hearing test results and be like, okay, now that I see what we're actually working with and I know that what you want to accomplish, here's what I recommend. And so you could essentially, I feel like it's my job to whittle through down all the decisions. I mean, as a doctor, you wouldn't be like, okay, here's the 18 different prescription medications you could try for your condition. Which one would you want? It's like, you wouldn't do that. So you would recommend either a lifestyle change or you'd recommend some type of a pharmaceutical or something other than that, right? I think it's the same way with audiology. We should be recommending what we believe the best option is to overcome the patient's hearing difficulties. And if the patient does not agree, let's say that I have the receiver and canal option, they're like, well, I really want something that goes all inside of my ears. No problem, we can accommodate that, and as long as I educate you on what the potential pros and cons of that would be, and you still want to move forward with that option, we can do that as well. But that should never really feel like it's an overwhelming thing. The only decision that someone with hearing loss should really have to make once they get presented with this information is, do I or do I not want to hear better? And do I want to treat my hearing loss to achieve that? That's really the only thing that they should have to answer. They should not be having to decide between different nuances of different devices.
Well, they might have to answer the question of budget.
Yeah,
Right.
I mean, so budget is definitely a thing for a lot of people. But I would also say this, if you live in the United States anyway, you have so many options. You can go the complete charitable route. There are organizations, at least in major cities here, there's charitable organizations that you can go to. And if you're someone and sometimes they have you prove that like you're low income, and they will literally give you hearing aids, or they'll do it on a sliding scale of affordability for individuals. I volunteer with an organization called Hearing the Call out of Tucson. There's a clinic that will do a sliding scale for people. If you cannot afford hearing aids, you can get hearing aids. You've got Costco out there that will sell prescription hearing aids for like, I don't know, $2,000 or less, which in the grand scheme of things from a prescription level hearing aid is relatively low cost. And then you can go into really high-level best practice clinics. And if you tell them, hey, I have a cost limitation, what can you do to be inside of my budget? Here's what I can afford. They will likely find an option. They might have to sacrifice certain features and capabilities of a device, certain technology levels of a device. But at the end of the day, they'll give you an option that can work within in your budget if that budget is realistic. And then on the other end, you have people who they don't care about price. They just want the absolute best hearing that they can possibly get, and then of course they pull no punches in terms of getting the best tech possible.
Mm-hmm. But it sounds like along with the best tech, there's selecting the hearing aid, but then you also need fitting and adjustments, right? So
That's
can
right.
you take us through a little bit what that part of the process is? And so for me to recap, you said first it's really interviewing them with like, what are the difficulties you're having and maybe the situations you find yourself in, right? Where you are struggling or things you would like to be able to achieve. And do you have a questionnaire that takes people through that?
Yeah, we have a full deck and I actually have a PowerPoint. Some people are more visual, so I'll give them
Uh-huh.
like visual examples of these types of situations because they might not be thinking of these things readily. They might
Yeah, give
have
us a few
difficulty in
examples of a few
yeah.
communication situations so people know what you're
Yeah,
referring
so
to.
so you've got these one-on-one and quiet. Like it seems super basic, but they're like, "Oh yeah, actually when my wife is facing away from me in the living room, I can't hear anything that she's saying." "Oh yeah, TV actually, I increase the volume of the TV, but that just makes it louder. It doesn't make it any clearer." When I'm in the car, the road noise actually makes it to where I can't understand the person in the back seat when they ask me a question. Like these are all types of questions that will or environments that we will mentally put them into so they can be like, oh, yeah, I never really thought of that. But yeah, I guess I do have difficulty there.
Uh-huh.
Sometimes people come in, they're like, I don't think I have difficulty, but my spouse thinks I do. And then when we take them through all the questions, it's like they self-reported like 7 out of the 10 questions that we asked they had difficulty with. So
Uh-huh.
so we can't just rely on them to self-report just by asking them, okay, tell me where you had difficulty. We have
Right.
to take them through a guided kind of experience with that
Mm-hmm.
so we can really uncover the areas of difficulty so then I can make the proper recommendation. And if I don't do my job well there, then we're going to end up recommending the wrong treatment for them.
Okay. So based on that and the audiogram results, I assume, and the budget, you'll recommend a few options and they might select a hearing aid and then take us through the rest of the process of getting these hearing aids to work for them.
Yeah, so in some cases, we do not need to do any type of like digital ear scanning or physical impressions of their ears based on what hearing loss level they have. Some people do need that if we need to get a custom ear mold for the hearing aid. If that happens, we cannot schedule them right away to get a fitting. We have to send that impression off to the manufacturer, get a custom ear mold made that we attach to the hearing aid that was selected, and then we can essentially initiate their fitting appointment. The way that we do it in my clinic is a little bit different than most clinics. We have a 45-day best practice fitting sequence. Patients will come in for 4 visits over the course of that time period, either in person or we do have some virtual capabilities with that as well. But we have their initial fitting. What we do at the initial fitting is we physically fit the hearing aid to their ears. We have to make sure that we have a good physical fit from a comfort standpoint and acoustic standpoint before we then move into the real ear measurement that I mentioned earlier here.
Uh-huh.
Okay. We do their verification measures. We have to ensure that we're able to use that hearing aid to match their prescriptive targets. If we cannot match their prescriptive targets, we either have to make a change on what our initial treatment recommendation was, or we have to come to a mutual agreement of, okay, we're not able to perfectly treat your hearing loss in this frequency range. And if they decide that they don't want to switch to a different hearing aid, then we see what we can ultimately get for them with that particular piece
Mm-hmm.
of technology.
Okay.
Once we do that, we take them through the basics, like get the hearing aid inside your ear, get it out of your ear, put it in the charger, answer a phone call with the hearing aid in your ears, right? So there's
Uh-huh.
certain basic things that we cover, and then we have to cover legally through the purchase agreement so they understand what the warranty is on the hearing aids, how long the return period is. Most states have a mandated return period where if you're not satisfied with your treatment after 30 days or so, or rather within 30 days, then you can take that hearing aid back for either a full or partial refund. So there's a lot of that type of stuff that we have to cover so the patient knows what the expectation is by the time we're done with the fitting. So that's the first appointment of your fitting appointment. It's in our clinic, it's an hour and 15 minutes, mostly my responsibility to make sure that I do my job correctly. But I do like to explain everything we're doing as we're doing it so they have a concept of what we're trying to
Mm-hmm.
accomplish. Then have them come back 1 week later. We tell them that they should be taking notes about the things that they're hearing better and the things that they're not hearing better. And that way we can go through that entire list of notes that they have and go in and specifically make adjustments for all those things.
Uh-huh.
Once we do that, we go over their data log. So hearing aids kind of tell on patients nowadays. They can see
Hmm.
what types of environments you were in, what they did automatically, what volume adjustments patients were making. So we can use that information to better adjust them going forward. Then we have them come back for a 3-week follow-up and a 6-week follow-up. At the 6-week follow-up, we've already had several sessions with them to where we've customized the audio. Usually at that time, they're like, but I can't think of any other environments that I want to improve upon. I'm really happy with these hearing aids, but we still do a validation outcome measure because it's considered best practice. So these are things that we pre-identified in the earlier on visits that they are going to give us subjective reporting on. So I can do all the objective stuff correctly in the fitting process. At the end of it, we literally go down the list. If their priorities were, let's say, television, how much better are you hearing on the TV? And we have a scale that they rate. The next one is hearing your wife in the living room when her back is facing you. How much better are you hearing there? They rate it on a scale. And typically by the time that we're done, we want to see that someone's either in the better or much better category with their hearing aids. And if it's anything less than that, usually there's a reason. So, and I'll give you a for instance here quickly. If someone did not want to use Bluetooth to stream phone calls directly into their ears so they could hear better on the phone, and they still have difficulty on the phone with holding the phone up to their ear, well, that's something that I could improve if you let me improve it. But if you choose that you do not want to let me improve it, then I'm sorry, you're going to have to be suboptimal when it comes to that situation.
Okay. Great. And so it sounds like if people go through that, they generally end up with a really good outcome. Now, can you speak a little bit to the adjustment period for the brain? You know, I've seen this said many times that getting your hearing corrected is not like glasses where when you have the right prescription, you can see clearly right away. That, it also takes some time for your brain to make adjustments. Can you speak to what that's like and what people should expect? And how do they know that, how do they know whether they need to wait for their brain to get used to it versus like the settings are not right?
Yeah. So the research tells us that it's around 30 days for the brain to fully adapt to hearing treatment. So what that means is that day one, when you're adjusted all the way up to your full prescription and you have it verified with real measurement, for most people, that is too much amplification all at once. So what we'll do is we'll back down the level of amplification. So we give them some amplification, but not so much to where they're like, I got to take these out of my ears. This is just mentally exhausting for me. And so over the course of the first week, they identify, like I'm getting more used to this. So it does get better day by day. It's not like everything is horrible until day 30. It's like, no, everything gets better day by day. The sound of your feet walking on gravel, the sound of the grandfather clock that was ticking and driving you crazy the first day, by day 7, your brain has adapted to that sound and it knows that it can ignore it if it wants to. And then at that first week follow-up, we increase the amplification a little bit. And they're like, okay, like I'm getting a little bit more here. And we do that progressively over the course of that 30 to 45 day window. So by the time they're at the end of that fitting period, they know that their brain has been fully adapted to the amplification levels. Now, the thing that people have to caution themselves with is that if a hearing care professional is like, oh, well, you're not doing well with your hearing treatment, just try it for another couple weeks and you're at like day 60 or you're at day 90 and your hearing care professional is like, oh, well, it takes the brain time to adapt. It does not take the brain that long to adapt. The vast majority of your adaptation happens in that first 30 days.
I mean, it sounds like what you're describing is that initially it's almost like too much input for the brain, right? So it's not that you're having trouble deciphering it. It's just that it feels like too loud, too much, too tiring.
Yeah, you will definitely be hearing better, like literally day one. You do not leave an office at a hearing aid fitting and not hear better, right? As long as it was done correctly. But yes, it's just overwhelming because your brain wants to process auditory information in the auditory cortex. It's very easy to remember because it's like right above the ears on both sides, right? When you go through long periods of time of auditory deprivation, like you would have with untreated presbycusis, then different areas of your brain are actually compensating for that and trying to fill in missing gaps for you that you're not actually hearing. And then when you reintroduce amplified sound back to the brain, all of a sudden these neurons that are in your auditory cortex are starting to fire again and they're like, whoa, what's going on here? And so it takes them time to kind of readapt to that. Similar to how when you wake up in the morning, you turn on the light switch, you're like, oh my gosh, like that's so bright. And then after a minute or so, you're like, oh, well, that's totally fine. It's because your eyes, the cones and rods inside of your eyes end up adapting to that change, just like your brain has to adapt to the amplification of a hearing aid.
So it sounds like people should generally expect that it's going to be a process of sort of scaling up the amplification and
100%.
input over a month. And it should be doable within a month.
Yeah, if you feel like your initial fitting, like, oh, that just sounds supernatural. This sounds that means that you're probably not being amplified appropriately because it's not challenging your brain to receive more auditory input. And so that's one of the dangers of the first fit method, which is not verifying the programming. Hearing aid manufacturers know that if they give you too much amplification early on and a hearing care professional doesn't counsel you properly with that, that it leads to an increase in hearing aid returns back to the manufacturer for a refund, and they don't want that. So
Right.
their solution to that isn't to make sure that the hearing care professional is following a best practice protocol. Their solution to that is under-amplifying people, which leads to poor treatment outcomes.
Okay. In a bit, we're going to do a separate little episode about dementia and people who are having difficulty with like their cognition, their memory, and thinking. But really briefly, is it about the same process with them and they just need longer?
Individuals with dementia typically no. They can go through the same auditory adaptation at the same speed as someone who does not have dementia. Now, sometimes this is, and we'll cover this in future episode, but sometimes you have individuals who presented what seemed to be a more advanced stage of dementia, almost seem like they kind of revert back a little bit in a good way to where it's like, oh man, I guess some of the dementia characteristics that they were exhibiting were just because they couldn't communicate. They couldn't hear and understand and communicate back effectively. And so we see that a lot with individuals who have dementia, that they actually perform better from a communication standpoint despite the dementia.
Right. Well, it's also, they're usually like working really hard to decipher what's going on along with everything else, right? So if you can make the hearing easier, they have more mental bandwidth to do all their other cognitive processes.
For sure. Yeah, like working memory is a real thing. Like if you're using all your working memory to struggle hearing, and then you can free up some of that working memory to do other things, that absolutely helps you out.
Yeah. And that's one of the reasons why, of course, they now describe hearing loss as one of the most modifiable, important risk factors for dementia and encourage people to get it detected and treated earlier, right?
Absolutely.
Yeah. And now you mentioned Costco hearing aids a little while ago, but I also saw on your YouTube channel that you have a video saying you don't recommend them. So
if you watch,
I didn't watch the video. I just saw the headline. It's a good headline. Of course, I know lots of people who go to Costco, and we think of Costco as a good option. So can you just briefly speak to the pros and cons of the Costco approach?
Well, you have to watch my full history. So I've been doing YouTube content on just all hearing loss and hearing aids and Costco since 2017. And so I have several videos that are very pro Costco, like in favor of them. You can kind of see a trajectory over the course of time where it's become slightly more negative as time has gone on. But at the end of the day, it really comes down to Costco has good quality hearing aids. Okay, they are not the name brands that you would recognize of the big manufacturers that we all know put out the best hearing aid technology, but they have really good technology that is manufactured by some of the same manufacturers. It's just different under a different brand name. So some of the things that I love about Costco is that you don't have to make a sacrifice when it comes to the advanced level of the technology that they dispense out of there. Where I have issues and that leads to any aspect of negative content that I create around Costco is if the hearing care professional who's fitting you and programming those devices in your ears is not following best practices, and even more important than that, following them in the right manner with a high level of expertise, you can get Costco great hearing aids and still not hear very well. Costco continues to be the best referral source for my clinic out of any other clinic that we get people who come over who are not happy with their hearing treatment. So I can't unequivocally say that like, oh yeah, go to Costco, you'll get great hearing aids and you'll do great. I can't say that because there are a lot of people who go to Costco and have disastrous treatment outcomes at Costco. There's also people with more basic level hearing losses that go to Costco, and they are lifelong advocates that Costco is the best place to go to treat your hearing loss. So, you just have to understand what the pros and cons are when you choose to go the Costco route.
So it sounds like they're a big operation at scale. They get a good product, but of course, the hearing care professionals who are there might be variable in quality.
Absolutely.
And people...
And to be fair, that is true across private practices. It's true across hospital groups.
Right.
It's true in retail locations. Like, it's true across the board.
Right. Because you said Only 30% of them are doing the real ear measurement.
That's right.
And can people buy their hearing aids at Costco and then come find a better hearing care professional to
They
do the
absolutely
fitting and
can.
adjustment?
Yeah, as long as they have the expectation that that professional is likely going to charge for their time. It's one of these things that for some reason the hearing care professional world has done this thing where they sell these bundled hearing aids. So all the services are included with the hearing aids. So what it's created is this perception across consumers that, oh, I bought the hearing aids, but all the services have no value because when you get hearing aids, like the services just come with them. They're gratis. They're free, right? And so they sometimes have this disconnect when they come in. They're like, oh, but I bought the hearing aids. What do you mean that these 3 hours that you need to spend with me to fix the hearing aid programming issues is going to cost money? So some people don't make that association. It's important that they do, though.
Okay. Well, great. Well, this has been so helpful. I'm sure this information is just going to help lots of people get a better experience in treating their age-related hearing loss. Any last tips for people or things that you think older adults should know about treating their age-related hearing loss?
Yeah, well, I mean, I hate to self-plug here, but, I have thousands of videos on my YouTube channel educating individuals on what to look for when it comes to hearing treatment. If some people want to identify what hearing aid would be best for them, and they can find that stuff on my channel. But I would say if you don't want to bog yourself down with endless hours of YouTube content, probably the easiest thing to do would be go to my website, hearingup.com, and find a Hearing Up Network member in your area. These are all professionals that I've vetted who follow comprehensive best practices. There's over 200 places that you can go throughout the United States now in order to find a really high quality hearing care professional if getting optimal treatment outcomes is really what you're looking for. Other than that, everyone has to be their own self-advocate here. The hearing care profession is not set up to operate in a patient's best interest. I hate to say that. I mean, it's a horrible thing for me to have to say, but it's not. Like the hearing aid industry.
It's true of all of healthcare.
Well, there you go. So like
Sadly.
You have to, as much as you want to trust, even me, maybe, right? You still have to have some level of understanding of what you need to do to make sure that you have the right treatment administered for you. So educating yourself is very important when it comes to healthcare, and that includes hearing healthcare.
Okay, great. Well, Dr. Cliff, thank you so very much. And we'll be sure to share the links to your YouTube channel and website with the show notes as well. Great.
Thank you for having me.
And with that, thank you so much for watching. If you found this helpful, you're here on YouTube, please go ahead and subscribe. It does help more people find the channel. If you've been listening to the audio version on the podcast feed, come take a look at the video if you get a chance. You'll see my key points on the screen. And again, if you want to support my work, it's always an option to join as a member of the Better Health While Aging YouTube channel as well. So thank you once again. I look forward to seeing you all soon on a future episode of the Better Health While Aging video podcast.